Good evening, everybody. We are now ready to commence today's session. Thank you for making the time to be a part of this important panel discussion titled Why India Needs a Suicide Prevention Strategy Now. My name is Tanya Fernandez. I am a research associate at the Center for Mental Health, Law and Policy, Indian Law Society, Pune. Before we start, I'd like to introduce Preeti and Aniket, our sign language interpreters, who will assist us with the sign language interpretation of this entire discussion. The switch between each sign language interpreter will occur every 20 minutes. Thank you, Preeti and Aniket. It is with great delight that I welcome you to today's panel discussion, co-organized by the Keshav Desiraju India Mental Health Observatory and Suicide Prevention and Implementation Research Initiative Spirit, both projects at the Center for Mental Health, Law and Policy. Before I introduce you to our esteemed panel of speakers, this is a trigger warning. During the course of today's discussion on suicide and suicide prevention, if you feel disturbed or distressed by the content, please step away and reach out to someone you trust or call a helpline. We've shared a few numbers in the chat box. It is now my pleasure to introduce you to our speakers. First, I would like to introduce Ms. Urvashi Prasad. Urvashi is a director in the Development, Monitoring and Evaluation Office at Niti Aayog. She has extensive experience in health, nutrition, sanitation, gender, and public policy. For 5 years, Urvashi worked as a public policy specialist in the office of the Vice Chairman at Niti Aayog. She has been a part of the core team supporting the work of Government of India's Empowered Group 1 for managing the COVID-19 pandemic. Urvashi co-authored India's first voluntary national review presented at the United Nations High-Level Political Forum on Sustainable Development in 2017. She has over 100 publications to her credit. Urvashi is a member of the World Economic Forum's Expert Network. She completed a BSc in Life Sciences from University of Birmingham, UK, followed by an MPhil in Bioscience Enterprise from University of Cambridge, and an MSc in Public Health from the London School of Hygiene and Tropical Medicine. A warm welcome, Urvashi. Thank you for being here today.
Thank you.
Our next panelist is Mr. Arjun Gupta. Arjun is a lived experience advocate and counseling psychologist from Hisar, Haryana. He has written 2 books on mental health to make mental health more accessible and understandable for lay people. He went through an episode of severe clinical depression in between 2015 to 2017, including multiple suicide attempts. Today, he hopes to help others in a similar position through advocacy and psychotherapy. He is currently building Mind Tuition, a platform that psychologically trains students preparing for competitive exams to ensure performance on the big day, along with counseling support for those in vulnerable positions psychologically. Arjun, thank you so much for agreeing to be a part of today's discussion.
Thank you, Tanya.
Our final speaker for this session is Ms. Preeti Sridhar. Preeti is the Chief Executive Officer at Mariwala Health Initiative. She focuses on building the grants portfolio, which is primarily community-led, and she spearheads the advocacy initiatives where she leads the work on suicide prevention, workplace mental health, working with the government and collaborating with funders to invest in mental health. Preeti has been able to conceptualize and implement programs and training to build the mental health ecosystem in India. She has 25 years of work experience and has worked with not-for-profit organizations working on the issue of mental health, child rights, and hopelessness, as well as with for-profit organizations in banking, financial services, and ratings. Preeti has extensive knowledge in finance, strategy, and human resources, and aims to combine these experiences with her interests in rights-based mental health to spotlight and support organizations and leaders providing community-based interventions. Welcome, Preeti. Thank you for joining us today.
Thank you.
We have just been informed that due to an urgent meeting that has suddenly come up, Ms. Kanimoli Karunanidhi may not be able to make it for today's event. We are still hopeful she will join us later in the program if possible, and we are constantly in touch with her team. Without much ado, I would like to introduce our moderator for this discussion, Arjun Kapoor. Arjun is a program manager and research fellow at CMHLP. He is a lawyer and psychologist by qualification. After graduating from Nalsar, Hyderabad, he was appointed as law clerk to the Supreme Court of India. Subsequently, his work focused on developing social legal interventions with access to justice for marginalized communities in Gujarat. Arjun has an MA in psychology from Ambedkar University, Delhi, with a specialization in interdisciplinary approaches to psychology. At the center, he co-leads various projects on law, policy, and service reform for mental health and suicide prevention. He works with a range of stakeholders for implementation of the Mental Health Care Act 2017 and the National Mental Health Policy 2014. He co-leads the Keshav Desiraju India Mental Health Observatory, Outlive, a suicide prevention program which addresses urban youth suicides, and Engage, an adolescent suicide prevention program based in Chhattisgarh, India. He is deeply invested in exploring the intersections of the human psyche, culture, and social justice. I would now like to hand the mic over to Arjun, who will provide an overview of today's discussion. Over to you, Arjun.
Thank you, Tanya. Good evening, and thank you all for joining in today's panel discussion. The National Crime Records Bureau, which is the official agency that collects data on suicides in India, has recently published its report on suicides for the year 2021. I'm afraid the figures don't look encouraging. According to the NCRB, suicide deaths have increased by 7.2% in 2021 as compared to the previous year, 2020. India's suicide rate, as per the NCRB, currently stands at 12 for every 100,000 individuals or persons, the highest it's ever been in the last decade. Just in the last 10 years, since 2011, suicides have increased by an overall margin of over 21%. Suicides are also the leading cause of death among young people aged 15 to 29 years in India. In fact, in 2021, 40% of suicides were among individuals who were below the age of 30 years, and this includes children and adolescents. Do bear in mind that the NCRB data is actually an underestimate of anywhere between 30 to 75%. So it is accurate to assume that the actual number of suicide deaths in India is far higher than what is actually officially reported. I don't mean to sensationalize the issue of suicides, but I do wish to emphasize, in light of some of these figures, that India is in the grips of a public health crisis. And the question remains, is India doing enough to prevent its people from dying by suicide? For far too long, suicide in the mainstream narrative has been understood as an individual issue and has been approached through a biomedical lens, which has invariably reduced suicide to a single factor in a person's life, such as mental illness or any other factor. However, it is now scientifically established, and we know well, that suicide is actually a complex phenomenon. It is a multifactorial phenomenon which cannot be reduced to one cause. On the contrary, there are multiple causes and factors which interplay with each other and compel an individual to take the decision to end their lives. And invariably, these factors are social, economic, and cultural in nature. The World Health Organization calls upon countries to develop a national response to suicide prevention by creating a national suicide prevention strategy, which is multi-sectoral in its approach. Now, what does this mean? This means that suicide prevention requires a coordinated and collaborative multi-sector response that involves not just the health sector, but other sectors such as education, labor, employment, agriculture, access to justice, and of course, the media. Yet, despite contributing to 1/3 of the global suicides, India is yet to have its own national suicide prevention strategy. So what can we, as civil society, researchers, activists, policymakers, and most importantly, citizens, people with lived experiences, do for developing a comprehensive and intersectoral national suicide prevention strategy? More importantly, how can such a strategy address the multiple causes of suicides in a country as diverse and unequal as India? It is my privilege to be in conversation today with our guest speakers on some of these crucial questions and the roadmap for developing a national suicide prevention strategy. The format for today's event is a panel discussion. Over the next 1 hour, I will pose questions to our guest speakers on various aspects of the theme. In the last 15 minutes and throughout the discussion, we will also invite questions from the audience. So please feel free to share your questions in the chat box. And if possible, do share your name, your background, and who you wish to address these questions to. We will try our best to address as many questions as possible, time permitting. So without further ado, if I can kickstart this discussion, and if I can begin with you, Urvashi. The United Nations Sustainable Development Goal 3.4, which speaks about promoting mental health and well-being, actually has reduction of suicide rates by 1/3 by the year 2030 as an indicator. Now, as per the NCRB's data, India's suicide rate has actually increased in the last decade by 7.14%, and it has reached its highest in 2021 since the last 10 years. As a member of the task force for overseeing the implementation of the Sustainable Development Goals in India, how do you think India is placed to achieve this goal of reducing its suicide rate? And how will a national suicide prevention strategy help us get anywhere close to this goal in the next 7 years? Over to you, Urvashi.
Yeah, thank you for that question. And I think, as you've already set the context for this discussion, the numbers are definitely very worrying, and as you said, likely to be underestimated, perhaps by several orders of magnitude. So I think that is something which is definitely a big concern, and equally so in the policy making sphere. But I think, as you said, that this is something which requires a multi-sectoral approach, and I think the time is absolutely right for us to have this discussion, because in light of the COVID pandemic, we've seen a worsening of the mental health situation, in many ways. As you already said, that it's anyway a multifactorial challenge, and the pandemic has added yet another element into that mix. So this is a very, very appropriate time to be having this discussion. And I think the strategy at the national level needs to engage all the different stakeholders. So I think firstly, within the government itself, we need to ensure that this narrative is actually built into the work of different ministries and departments, because like you rightly said, that it's not just a health issue. So it's not just the Ministry of Health, which should look at it, but equally the Ministry of Women and Child Development, Education, Agriculture, Information and Broadcasting, from the media point of view, labor and employment, so every sort of different ministry and department, which we don't normally think has a role to play, in suicide prevention. Actually, they probably do have some sort of role to play, either directly or indirectly. So I think that is something that we need to, build into our policy making, is to make sure that this narrative around mental health, narrative around suicide prevention, is actually a part of the different policies that different ministries are actually implementing. So I think that is something we need to do within the government sphere, but we obviously need to go beyond the government, because a big challenge like this is not going to be tackled by the government alone. So a national strategy has to bring together private sector, civil society, individual citizens, people who have lived experiences, because they are perhaps the ones who can, talk about it best. So I think, faith leaders, community leaders, elected representatives, I think we need to integrate all of them, because we need to also break the stigma and the shame associated with this issue. One of the reasons why we don't, perhaps have a kind of national integrated strategy, because it's not a topic that we normally talk about very openly. There's a lot of stigma, there's a lot of embarrassment, a lot of shame. A lot of times we attribute it to an individual's weakness. So I think in order to break all these, views and biases down, we need to involve every possible stakeholder that we can. Just the government alone is never going to be, able to do it successfully. But of course, the government and policy has to be, a very important part of it. So I think that, we do have a long way to go in achieving our goals. There's no doubt, but the time is absolutely right for us to make sure that we have this integrated national strategy, and we have all stakeholders working in their different domains, but overall contributing to this goal of reducing the mental health crisis in the country, and as well as preventing as many suicides as possible.
Right. Thanks for that insightful intervention, Urvashi. And I think you've highlighted an important point of engaging different ministries, because all of them have a role directly or indirectly. And as the WHO says, having an intersectoral sort of approach is key to addressing suicide prevention. And I'd like to sort of come back to you in the next round to sort of explore how we can actually develop a roadmap for that kind of intersectoral coordination. But now, if I can move to you, Arjun, like sort of I initially mentioned that suicide is the leading cause of death for young people between the ages of 15 to 29, and in a country where over 50% of the population is below the age of 25, that is a really telling figure and statistic. And it also sort of, kind of establishes the fact that young people, and especially a diverse youth population in India, is definitely one of the most vulnerable groups in the context of suicide. And also to put this into context, Arjun, young people in India and across the world have also been experiencing a period of flux in these times, with the pandemic, with the influence of social media, increasing inequality, discrimination. As someone who regularly engages with young people through your own advocacy, what, according to you, are some of the key concerns that are being experienced by young people, which can explain some of these alarming trends in the context of suicide? And can you identify some areas that a national suicide prevention strategy should focus on to address the needs and concerns of a diverse youth population in India? Over to you, Arjun.
Thank you for that, Arjun. And you make some good points about the world being in flux over the last 2-3 years and how things have been changing very rapidly in this time for youngsters across the world. And in my experiences, the conversations I've had with young people, two themes emerge over and over again, which is the first is education. So going over the NCRP report, you see that % of the people who died by suicide in last year were students. So there is a lot of pressure which goes along with any education system that we have in India, whether it's the state's system or the central system that we employ right now. And with the increasing emphasis on competitive exams, so we have a common entrance test this year for admission into all universities. There's the NEET, JEE, UPSC. Those examinations just add to the pressure of do or die for these students. And when you look at it at a deeper psychological level, it's ultimately an identity issue that comes up, where a lot of youngsters are lost in what they want to be and what they wish to be. They feel like they're living the lives of their parents or their friends, and there's a lot of identity conflict that goes on at this time. So First is education, focusing on how to ramp up or maybe change the education system so that it's more inclusive to people's different needs, or it's maybe more open to different people and a bit less competitive. Maybe we can deal with at least 10% less competitive exams. And next, you mentioned about social media, and ever since the pandemic hit, it was basically social media that was keeping us all together at that time, and it was giving us a sense of community, a sense of belonging at a time when we were completely detached from the physical world. The thing is, social media is run by algorithms, and algorithms just give us what we want, and that leads to a huge chance of radicalization or um, just extremism in behavior, no matter what kind of behavior it is in youngsters. So at this time, there is a lack of a very clear moral compass. We are trying to explore our identity. We're trying to see what's right and what's wrong. We are trying to build our own values. And at that time, when you have a whole algorithm that is trying to um, sell you and your attention to something else, that leaves you very vulnerable. So when we talk about, the intersectoral approach that we're taking, it's not just about the ministries that we have to involve. It's also the digital big tech that plays a huge role in the lives of youngsters in the modern world. And if we are to make some meaningful change, I'm not sure that if we want to regulate big tech, but at least there must be some understanding of how this digital algorithm affects the young minds in the world today.
Right. Thanks, Arjun. I think you again raised some really important points, and I do resonate with your point about, especially about the education system, which is overtly competitive and subjugates young people to all kinds of pressures, but also at many times is exclusionary, leading to different forms of institutional discrimination. And I'd like to come back to you at a later stage to sort of explore how we could be addressing some of these concerns at a policy level. But for now, if I could come to you, Preeti. Preeti, we know that suicides have various social determinants, right? Including, sort of discrimination based on caste, gender, sexuality, and then you have various groups which are particularly vulnerable due to socioeconomic pressures. So, for instance, informal or daily wage workers, who incidentally constitute one of the, the highest groups in terms of suicide deaths for the year 2021. Now, MHI recently came out with a report titled "Suicide Prevention: Changing the Narrative," in collaboration with the Alliance for Suicide Prevention. And this report basically advocates for reimagining and adapting a multi-pronged suicide prevention approach, where you have highlighted the importance of community-based, rights-based, and systemic approaches to suicide prevention. Can you tell us a little bit about what does this actually mean? And also, what can civil society do to create coalitions with marginalized communities and social movements to ensure that they are leading efforts for advocacy and policy reform on suicide prevention? Over to you, Preeti.
Thanks, Arjun. I think when we are talking about suicide prevention, we need to understand that suicide or suicidal thoughts can be experienced by certain cohorts or groups much more, or they are at risk because of the discrimination that they experience in the society. And therefore, any work that we want to do with marginalized group, one needs to have an affirmative approach to the entire work process, which means, first of all, understanding your own positionality. So for MHI to understand that we are basically a funder, and then we have some power, not some, we have a lot of power when we're talking to NGOs who are working in the mental health or suicide prevention sector. It also means building our own understanding of the issue first. We cannot expect different marginalized groups to take the onus of teaching us on what are the experiences that they have, how does it impact them. Third, it's also important, if you want people with different marginalized experiences, with different lived experience, to be part of those conversations, to create a safe space for them to share. And finally, I think acknowledging that when you work with marginalized groups, they need to be compensated, not just in monetary terms for their time and effort, but also providing acknowledgement to their contribution to the entire work. So even when we talk about Bridge the Care Gap campaign or Alliance for Suicide Prevention, we say all of this movement building comes from our knowledge of previous movement building on other issues that have happened. For MHI, working with marginalized groups on suicide prevention means that we do a lot of interactions. So over the last 2 years, when we have done this work, that is even before the report, we have been speaking to various mental health professionals, we have been speaking to experts. We have also done multiple consultations with people from marginalized backgrounds and lived experiences to understand what are issues that concern them, to understand what are the gaps, where would they want the first efforts to go in. And when we talk about lived experience, for us, it's not to say lived experience is a common uniform cohort, but to also look at within that intersectionalities of different marginalization, within lived experience intersectionalities of, say, living with suicide, being a survivor of suicide, or having lost somebody to suicide. We also realized during a lot of our work that if we want to reach out to people and engage more people from marginalized backgrounds in our conversation, our entire conversation needs to be in a language which is more accessible. And therefore, if you look at the suicide prevention report, the language is much more simpler compared to other writings that MHI does otherwise. It's also important that all of our material is accessible for people to freely download, translate, and use. In terms of, therefore, what our work with marginalized background, understanding suicide prevention, understanding of an intersectoral approach means is that we are looking at we did a lot of research on which are the organizations that are working with different marginalized groups. What does their work look like and mean? We did a lot of outreach to these organizations because, frankly speaking, there is so limited a conversation on this topic, and even less within the funding space, that you really have to find organizations that are doing suicide prevention work, probably in an unfunded manner. So to reach out to those. And then I think one of the learnings that we have had is because these organizations have been doing it without adequate resources and funding, we need to work with them in terms of co-creating a program that can be funded. So it is taking us a lot more time to work with these organizations that work with marginalized groups to create a program. And I think for MHI, therefore, or for me as a CEO to understand that working on suicide prevention with this lens and understanding that marginalized groups experience more risk and will need more effort from our side, I think I'm spending a lot of time in actually getting involved at the operational level for this kind of work. So for me, to do this kind of collective work on an issue that is highly stigmatized and not understood well enough, I think the leadership team will need to give the required focus. And as funders, we need to take the extra step of reaching out rather than expecting the collectives to reach out to us.
Yeah, thanks for that, Preeti. I think you sort of touched upon a lot of really important aspects about coalition building and building coalitions in an equitable manner, more importantly. And I think, I mean, you've raised a lot of important issues, but I think what also has sort of struck with me is a couple of issues around, of course, positionality, you know, to sort of understand for some of us who come from positions of privilege, whether it's in terms of caste, gender, sexuality, or otherwise, how do we sort of shift that balance and create a more equitable level playing field as as a duty and as an obligation. And also the importance of incorporating lived experiences in some of the co-creation work, where we're also sort of not just sort of designing programs from a top to the bottom sort of approach, but also following a more co-creative, more co-design sort of oriented approach. Before I move on, there's a question in the chat box. Urvashi, I'm wondering if you'd like to take that. And I think this question from Soumitra, and it sort of continues sort of the point about how do we address the concerns of young people. Any insights about how the Niti Aayog is planning to address the issue of suicides and specifically youth suicides? If you'd like to take that question on.
Yeah, so I mean, Niti Aayog, of course, we work with all the ministries and we also work with all the state governments. So in that sense, our initiatives are also aligned with what is happening at the central ministry level as well as at the level of state governments. So I think, the role we play certainly is to, make sure that the critical issues are highlighted in the policy arena. And this is certainly one of those, the broader issue of mental health and of course, suicide prevention as well. That making sure that is integrated into different aspects of policy making is really the role that we are trying to play. And I think it's an important platform, a platform like Niti Aayog, because like I said, we work not just with central government ministries, but also with state governments. And I think it's very important to understand that much of the action in India, at the policy level actually happens at the state government level. While the center has a very important role to play in putting in place those enabling frameworks and those, broad policy guidelines, ultimately it is the states which implement. And I think it's very important that therefore we engage with state governments and we also learn from the experiences of different state governments, because there are certain states which are sort of further ahead, ahead in this particular area. There are certain states which have more advanced policies or more sensitive policies to these kind of issues. So I think it's very important to also promote that knowledge sharing amongst the states themselves, because often when we talk of best practices, we talk about bringing in best practices from outside India. But one of the things we are trying to do in Niti Aayog is to also learn from what are the good practices happening within India, and trying to promote the sharing of those, across different state governments. So I think that is one of the big roles that we're trying to play. Because ultimately any strategy that we implement has to be customized to our context. We can't just bring in a strategy from somewhere outside and just sort of implement it here. We need to customize it to our cultural context, our social context. And I think in that sense, learning from the experiences of different states is actually very critical. And that is one of the roles that we at Niti Aayog try to perform, and I think we'll see more of that in the years to come as Niti Aayog evolves.
Right, you actually sort of preempted one of my other sort of questions, Urvashi, which was also in terms of given India's sort of quasi-federal structure where both the central and state governments have a very important role to play in the implementation of legislation, specifically in the context of public health. I also wanted to sort of just, invite you to speak a little bit about, how do we also then translate policy into action, both at the national and at the state level. And I'm also sort of foregrounding this question specifically in the context of intersectoral coordination, which you touched upon in your opening remarks. How do we get different departments of the government to speak with each other, and work with each other to design suicide prevention programs which address a range of contexts and diverse youth populations? So any insights about how policy can be translated into action, keeping in mind that often in our context, we encounter into numerous challenges in terms of implementation itself. So we might have policies in place, but actually translating them into action is what becomes difficult or problematic. So any insights on this, Urvashi?
Yeah, I think, first is it's really important to highlight why this is such a big issue. And to all of us here, it's obvious, we are all here because we understand it's a big issue. But when we're talking about, policy and policymakers at every level of the government, central government, different departments, state governments, different departments, there's already so much on their plate. There's already so much that they have to do. There's so much firefighting they have to do. It can feel like, okay, now this is yet another thing that you're asking us to do, and why is this so important? So I think it's really important that whatever statistics that we have, even outside the official statistics, because one, as you quoted rightly, we have the official statistics, but just based on the experiences of different organizations working in the space, we understand that there might be a lot more actually that is happening, which is not necessarily getting reflected in some of the official statistics. So I think continuously highlighting to policymakers why this is so important, what are the different segments that we need to look at, like students is sort of one category or one segment where we see a lot of suicides happening. We obviously see it amongst farmers, we see it amongst women for different reasons. So I think we need to highlight that first and foremost, and do it on a continuous basis. I think even the media has a big role to play in this. Not to talk about suicide just because some sensational case has happened somewhere, in the country, but to talk about this issue on a regular basis, on an ongoing basis, because it's not just about one suicide or one case. It is about something that people are, grappling with on a daily basis. So I think that is something very important, because why should a policymaker even prioritize this? And I think that is a role that we all have to play in convincing them that, this is something that you have to prioritize, and this is, these are the reasons why, and the statistics speak for themselves. So I think that is our first, barrier that we need to cross. Once we've done that, I think in terms of moving from policy to action, that is where working with different stakeholders comes in, because obviously the government through its own machinery cannot implement everything. There is one part of that. So, even if you look at the health system, health workers have to be sensitized to these issues, at every level. If you look at the education system, there needs to be perhaps some sensitization of teachers, right? That, you might have a student in your class who is actually, struggling with this. And how do you pick up those signs, or how do you provide that safe space, for them to express themselves? So we certainly need a lot of capacity building, a lot of training within the government system, but the government alone, like I said, at the outset as well, will not be able to do it. So that is where, the civil society, the other stakeholders come in. And can actually help the government take this from, policy to action, from, theory to practice. And I think, that is something that multi-sectoral, stakeholder and multi-sectoral approach can allow you to do. But it's very important to cross that first barrier, which is to say, why is this such a big issue? Why must we all prioritize it? Because if I'm the Ministry of Education, then I want to understand that, why should I care about this issue? Isn't this a health issue? Why should this bother me? Or if I'm the Ministry of Labor, I already have so many other things to do. Why should I care about this? So I think it's really important to convince policymakers at every level that this is not somebody else's problem. This is equally your problem, and this is equally your mandate. And I think once we've done that, then it's much easier to, move towards sort of implementation of any policies that we have.
Sure. Thanks for that, Urvashi. Arjun, if I could bring you in at this stage, and I'm sort of drawing from both what Urvashi and Preeti have spoken about. Preeti is, of course, spoken about coalition building, and also including lived experience, persons with lived experiences in the design of policies themselves. Urvashi has also touched upon sort of sort of highlighting to policymakers the importance of addressing suicide prevention and some of the finer sort of issues around how specific demographic groups in our country, for instance, women or people from the LGBTQ community or farmers or otherwise might be experiencing a whole range of stressors and risk factors of suicide. As a young person, Arjun, I'm sort of also interested in knowing about how we can engage young people in this process. And I'm sure you're aware of the slogan, nothing about us without us, which was really the slogan of the disability movement, which is now a movement, which is demanding from state governments that persons with lived experiences should be able to participate in decision-making bodies or developing laws and policies or programs that impact them. And this is equally important for young people who are experiencing mental health problems or thoughts or feelings of suicide, especially in a context, where there is a wide disconnect between policymakers or the older generation and the younger generation, or as you may call them, millennials or Gen Zs. So my question is, how can young people engage with policymakers to influence the design and implementation of a national suicide prevention strategy and other kinds of mental health policies and programs?
The first thing about devising any suicide prevention policy is that if you are going to include people with lived experiences, there will be a survivability bias there, because people who do have suicidal thoughts at the moment, they don't really want to talk about them most of the time. When it's experienced, like when you're experiencing those thoughts that your life is better off if it's over, at those times they're not going to be thinking about how to create policy that will help some other people, because, well, I don't want any help right now. I might as well die. So there is a sense of survivorship bias that goes into any policy that will go in. But working with what we have, I think there is a large power distance between policymakers and young people. So if I were to talk to any of my friends or any of my colleagues about what they think about policies on suicide prevention, they would be like, that's not my job. That's the old people will take care of it, right? And it's not like they're coming to us to talk to us about what we should be doing, what we need. So this is a good start, to be honest, that we are having this conversation where people are being engaged, especially young people are being engaged by people who are in charge, by people who have power to make those changes. But again, I am coming from a very unique context. I have a position in this economically, socially, educationally, and so there's only a very limited space for the context that is coming in, especially my own. So the first thing that we need to do is reach out to the youngsters, because young people have a lot on their plate as it is. As Urvashi was mentioning, that ministries have a lot on their plate, even individuals have a lot on their plate. We have to work on our careers, we have to hustle and work 18 hours a day. And at that time, if someone comes to us and wants our inputs on, how do we prevent more suicides, it might be like, bro, you just dekh lo. We don't know much. So I think the more we talk about it, the more conversations we have about it, the more opinions will come up about what people think. And there will be some opinions which will be like, well, suicide cannot be prevented and we should not be doing anything to do that. But well, if we take that defeatist approach, then we don't change anything. So it's about reaching out, it's about initiating conversations, and it's also about picking and choosing what sort of opinions we're looking for when we are going out looking for young people. Young people also have a lot of mistrust for policymakers. I'll be very honest. We're not very sure if there's always our best interests in mind when this is going on, when any policy is being made. So maybe building some bridges there, trying to make people, trying to at least build some confidence that what we want is in your best interests and we are willing to work on it. And if we have a policy, then it will be implemented as well. It won't just end up being a part of another paper law. It will be implemented. There will be some changes that will be made on the ground. And yeah, I think changes can be made. I think youngsters are looking for some options here about what they can do, about what can be done here. But as with any young people, we have a lot of energy, but very little direction. And yeah, we're looking for some direction, to be honest.
Thanks for that, Arjun. Preeti, if I could come to you now, and Arjun talks about the need for some direction, and I'm assuming support of especially for civil society actors to be engaging in the policy process. Could you talk about some of your experiences of working with organizations on the ground in to sort of in terms of how can policy translate into implementation, and more importantly, what are some of the kinds of resources that we need to be allocating? What are the kinds of capacity building needs that we need to be investing in, to build capacities of multiple stakeholders, not just for developing a national suicide prevention strategy, but also sort of ensuring its implementation on ground.
Sure. I think I'll start off by what Arjun Gupta was saying in terms of young people willing to provide their expertise on the issue, and not just suicide, I think, on any other issue that involves them, but there not be enough willingness on part of the policymakers to incorporate that. So when he was telling, I felt that I think there's a change required on both sides, from the policymakers side, to know that their knowledge is really dated, right? What works, what doesn't work, what is the need, what is the gap, all of that is very dated because they were young many years ago. So they don't know the reality of what does a youth today think. They also need to be aware that if they engage with the young people right from, say, a consultation at the beginning to designing the program and implementation, the impact will be greater. And again, coming to Urvashi's points, you have to think what is in it for the policymaker to engage with young people. So to say that, and I think for the young people, if there are people who are interested, because as Arjun was saying, not everybody wants to engage given their realities of those times, but those who want to engage at the policy and advocacy level, are we training them enough to take on this role, to be successful, to put their voices across, and are also we taking, I would say, adequate representation within young people? Because again, something that Arjun is well aware when he talked about his positionality, but we also say as a MHR that intersectionality within young people also needs to be understood. Not everybody, not all young people think and behave and want the same changes. So I think different voices within that. To the larger question about what kind of resources would civil society require to do this kind of work, I think if we look for a national suicide prevention policy that builds on existing work, where existing human resources are utilized or trained to give service deliveries on suicide prevention, it would make more sense because, frankly speaking, mental health professionals are currently limited. And you'll shift between the private and the public sector, but there is limited talent pool. So it would make more sense to use a non-medical model of capacity building, use existing resources. Because we have seen in some states, the hiring process itself, the hiring criteria itself does not allow programs to take off or kick off. There's also this need that when you are talking to multiple stakeholders, that there is clear roles and actionables defined for each of, say, the health department, the women and child development department, the labor department, etc. Because while all of it will lead to suicide prevention and reduction, their roles, their trajectories of movement could be very different. I think there's also a need for resources that can be developed at the center level to be made available to various states to adopt, interpret, make it culturally appropriate and use. Because not for every state, the priority may not be at the same level. So we are seeing certain states are ahead of the curve in their health systems, are ahead of the curve when it comes to their approach to suicide prevention than others. And if those resources could be shared across, even as a starting point, I think it would be great. And We do know that we have a great mental health care act, but it's not giving us the desired result because there is no adequate budget following that act. So I think a national suicide prevention strategy should also have adequate budget following. And while I think NMHP or DMHPs are the right modalities for delivery at larger scale, in the past, we have seen that one or two national level organizations are leading the mental health change across states. And that may not be the most appropriate way for budget allocation or delivery or content creation also, because the realities of different states are different. So for example, if there's one national level organization that's designing training on DMHP for suicide prevention, the reality of implementation in Karnataka could be very different from Himalayan states where DMHP may not be fully functional, whereas it is in Karnataka. Also, the target groups that each state may want to work on could be very different. So in Maharashtra, suicides among farmers is an issue that the state may want to or should ideally be working on. But the realities of suicide in Sikkim could be very different. So I think there needs to be a pool of resources made available, both in terms of knowledge and budgets. But the state should be given a free hand in what to access, what not to access, as long as they're delivering on the overall agenda. And I think I've been telling this to some of the state governments that the mental health indicators are not a part of NIHM indicators. And if you have an indicator to keep measuring, is there a movement on the agenda, it will make more impact. So I would like to see suicide prevention as an indicator or a monitoring mechanism within Niti Aayog or other places, so that states are forced to give it the priority that it deserves.
Right. Just to sort of take that point of indicators forward, Preeti, we've actually got a question from Arunjit Singh from the audience, who said, how can the system disparities be identified that push communities towards being marginalized? And are there any indicators or tools that can be utilized to understand different factors contributing to suicidal tendencies among young people and other vulnerable communities? Would you have any insights in this regard?
I wouldn't say insight. I'll share my views and would look for other panelists to share theirs. I think as MHI, we are not very much in favor of a tool system, because most tools people use on suicidality are Western models. And there is recent research that says that it's not as impactful as it is said to be. I would say let's just look at NCRB data. So for example, the NCRB data, while it, with all its weaknesses, also articulates that 50% of women who died by suicide were young women below 30 years. Take that data and then work backwards. Why is it happening within this cohorts? What are realities that young women experience? It could be that they get married early. It could be that they lose out on the education system because of that, don't have formal livelihood options, have a high dependency on their new family, limited natal family support. All of these are stressors that impact them. And therefore, what would change mean for them? So a right to education, a strong implementation of acts against child marriages, a strong act on domestic violence and protection under that. All these could then become protective factors for suicide prevention. I'm still a little uncomfortable recommending any kind of tools for assessing vulnerability.
Sure. Thanks for that, Preeti. I'll take that point on data because it's an important point. And if I come to you, Urvashi, at this point, you have previously spoken about shifting the focus solely from budgetary allocation for government schemes to monitoring outputs and outcomes to assess the impact and performance of schemes. And you've also sort of foregrounded the importance of data, of collecting data and evidence to ensure better formulations of schemes and also for implementation. Now, as we've already discussed in the context of suicide prevention, we know that the NCRB is the official agency for collecting and reporting suicide deaths, but we also know, according to various research estimates, that the NCRB data is underestimated anywhere between 30 to 75%, which is a huge gap. There are issues in terms of how the NCRB classifies the causes of suicide deaths. We know that attempted suicide data is not collected, and that's really important given the fact that for every suicide, there are anywhere between 4 to 20 suicide attempts. So you can imagine, the magnitude of the number of people attempting suicide but not dying by it. And the other issue with the NCRB data is also the absence of raw data, which helps us identify patterns between different demographic groups and the causes of suicide. And this is something that Preeti has also alluded to with her example of women and domestic violence. Can you talk a little bit about how we can improve data collection and recording mechanisms for suicides and attempted suicides, and how important is this for designing, monitoring, and evaluating both suicide prevention strategy at the national level and at the state levels also?
Yeah, I think, this is, one part of it is, of course, how do we improve the reporting? And I think that is a lot of that has to do with the stigma aspect, with the, with the shame, the embarrassment. A lot of it would not, people would not even come forward or willingly share or report something like this. So one is, I think that, and I think this is true for not just suicide, but, various other, issues also. We have a similar data challenge because people don't actually come forward and identify themselves as having that issue, and others around them don't make it easy either for them to do so. So I think one is that we need to, if we want better data, then we need to make it much more conducive for people to share and not be judged in doing so. So I think that is very important. We also need to assure people, and we need to have systems that, the data would be handled sensitively because, I come from a public health background, so I know that health data, for instance, is very sensitive, and people want it to be handled very carefully. And that is why we have a lot of discussions, around privacy and security of the data and ethics. And I think that applies here as well. What will you use this data for? How will you use it? It should not become something which, becomes a tool for discrimination against an individual, for instance, So I think that also needs to be assured to people, and those mechanisms need to be put in place that the data will be truly used, in the spirit in which it's collected. And it will help us to better identify the problem, to develop better strategies, but it will not actually be used to discriminate or, sort of cause any sort of individual level issues. So I think that is also very important. And I think then we just need, better integrated systems, because, like we've been discussing that, suicides are happening in different segments of the population for different reasons. They may be getting recorded in different ways, in the health system. So we need to have a better sort of vocabulary around that. We need to have a better integrated system, of capturing all this data. And we need to have our different, because today, most of the data systems are quite, fragmented. They don't necessarily talk to each other. So I think we need to have better, more interoperable sort of data systems as well, and a consistent vocabulary, which is used across, consistent classification, consistent definitions, because all of this might currently be varying, across different states in India. And that's why we probably see this sort of variability in the data. So I think these are some of the measures we need to take. Again, the stigma and the shame aspect is something which only the government doesn't have a role to play. I think all stakeholders have a role to play in that, because we need to make it, like we're talking about attempted suicides. We need to make it okay for somebody to share that information, to share that data, without actually being judged, or without having to be fearful of any consequences, and without being stigmatized for the same. Because I might be very afraid that if I come forward and say that I actually attempted suicide, I mean, what would be the consequences for me? Would that be held against me? So I think there's a lot of this sort of fear and concern, and that needs to be addressed. And we need to have mechanisms in place to address all of that. Otherwise, it will be very difficult to improve the sort of data situation on this. So I think it needs to be a holistic approach to improve our data sort of capturing, and it's not just technology tools, or it's not just integration, but it's also making sure that we address the stigma aspect.
Right. Thanks for that, Urvashi. I think you raise an important point about stigma, which has, of course, been a hindrance to the reporting of suicides, given the fact that suicides are reported by police officials. Given suicide is still on the Indian Penal Code, on the statute books. However, with the decriminalization of the attempt to suicide by the Mental Health Care Act, where the law now says that any person who has sort of attempted suicide is presumed to be under severe stress, and hence cannot be prosecuted under the Indian Penal Code, should go a long way, hopefully, in sort of destigmatizing this aspect. But we still have a long way to go there, given the fact that the criminal justice system, and especially police officials, need to be trained actively, because we know that even now, people who do attempt suicide are still being booked under the law, which is contrary to what the Mental Health Care Act says. And I think in terms of the models of data collection, I'd also like to just add that the Suicide Prevention and Implementation Research Initiative, which is being led by the Center for Mental Health Law and Policy, has actually developed a model for community suicide surveillance. It's a system that we have developed, where we sort of have sort of identified a mechanism to collect data on suicides and attempted suicides from the community itself, instead of relying specifically only on official records, say from hospitals or police officials, where there can be a lot of inconsistencies. And this model has also been recognized by the World Health Organization. So I hope that many such models can be sort of replicated, and we kind of work towards a more sort of integrated system of collecting data, which addresses some of the existing gaps that we are currently dealing with in terms of the NCRP. Just to sort of also stay on this point of data, I also just like to quickly touch upon the issue of research, because when we talk of course, data which is being collected by the government officially, but also research data, which is very critical for us to be developing evidence-based strategies for suicide prevention. And we do know that India is, of course, not investing enough in research. And I'd also like to link this issue with a couple of questions that have come in from the audience. So for instance, Joe Chopra says that I personally know 9 people who have died by suicide over the past 20 years or so. I also work in the field of disability, mostly within their own families. Is anybody on the panel aware of a connection between suicide and disability? We also have another question from Sonali Mirchandani, who's asking if we have any research data on the link between suicide and chronic health suffering. I'm just wondering if any of the panelists would like to address the larger question of research data, or the more specific questions around the link between suicide and disability and chronic health suffering.
Yeah, I can just share my views on the link, between suicides and chronic disability or chronic health issues. I think there is evidence to suggest And there is a lot of research on this and evidence. For instance, in cancer patients, you tend to see that the risk of suicide is significantly higher, and more so in younger cancer patients. And there is data to show that the risk is higher, and also there's also evidence on the time period during which the risk is particularly elevated. So in the first sort of 3 or 4 months after a diagnosis of such a condition, a young person is at a significantly elevated risk of suicide. So I think yes, we need more of that data, but there is data to suggest that there is a link, because a chronic health issue, a chronic disability, impacts your overall quality of life, impacts your overall well-being in many different ways. So there's certainly a risk of heightened suicidality in such populations that we need to be aware of. And again, this is something that the health system needs to be sensitized, because if I'm an oncologist, then I'll just be looking at the cancer aspect. I might not actually think that my patient is also grappling with depression or suicidal thoughts. So I might be an oncologist, but I need to be able to link my patient up with the right kind of support, and the right kind of mental health support, psychosocial support, So I think it's really important that we break down the narrow silos, in which different professionals operate, and this is, as I said, it's true in policy making, it's true at all levels of the system. And we need to make sure that, we are, even if we are not the right person to provide help, we should at least be able to connect somebody, with the right kind of help. So we should at least be able to pick up on these signs, or at least be able to, take it seriously when somebody expresses this. And make sure that we connect them with the right kind of help. So yeah, so I think there's definitely a link, and there's definitely evidence and research to support that. And I think the more research we do to highlight that, it can be useful, especially in capacity building of health workers, training, etc. We can build a case around why do you need to train specialists in these issues, or why do you need to train different types of health professionals to pick up these signs.
Thanks, Urvashi. I'm just checking if
if I may add, so the NCRB data also says that 19% of the deaths in 2021 were due to illness. Now, we cannot assume that they were chronic illnesses, but we could certainly assume that a significant portion of it could be individuals who themselves may have chronic illnesses. So again, I would say in the limited data that is there, also you could make these connections, but research as a subject within mental health, within suicide in India is very, very limited. If you look at suicide, the Mental Health Care Act decriminalized it only in 2018, 2017 onwards, implementable from 2018. So what it means is till then data itself, collecting that data itself would probably expose the person giving the data and on whose life you're collecting the data to be incriminated in a legal case. So it was not conducive to do this kind of research. The fact that even today all suicide attempts become medical legal cases means that the environment, the legal environment, the structural environment, and of course, as everyone has been talking, the stigma around the issue does not make it conducive to do research. There is a need to do research, but again, for us as MHI, we have been realizing that as we are getting newer partners and co-creating programs, we are telling them go for the implementation because there is an urgent need to do service delivery rather than standalone research. But also we are saying we will fund you additionally to do the research, to document it the way you think you would like to document your work. So it need not be academically approved research, but enough research to say that your implementation made an impact. So I think there is a need to take that. And of course, also look at research in neighboring countries, in other LMICs, which we could draw upon to say, that as we implement these in India, they may be successful, and those implementations can be documented.
Thanks, Preeti. Your comment is actually a perfect segue into my next question, which is addressed to you. Again, if I can refer to the report that MHI and ASP came out with, Changing the Narrative, the report showcases some good practices around suicide prevention intervention from the rest of the world. You've also touched upon sort of the challenges around doing research in a context like India, and I think it's also, and I think Urvashi also touched upon the point of data protection, which you've also raised. And it is important for us to say that India still lacks a robust, comprehensive data protection framework, which is critical for the kind of work that we are doing on mental health and suicide prevention. And of course, that's another discussion about how do we need to be approaching data protection in India's context. But just in terms of the fact that there are already existing evidence-based interventions which have proven to work across the world in perhaps similar settings like India, which are low middle income countries or developing countries. So maybe there's no need to always reinvent the wheel, but perhaps also look at how we can adapt some of these evidence-based interventions, and of course assess whether they work or not in an Indian context. Can you talk about some of these best practices that you think are relevant and adaptable in India's context? And what are some of the learnings that we can draw upon for developing a national suicide prevention strategy? Preeti, I think you're on mute. Yeah.
So I think in our report on suicide prevention, changing the narrative, we mentioned 5 such examples that we think are applicable in India, and also as MHR, we think fundable for work in India in case there is anybody looking to work in this space of service delivery. So we know that Sri Lanka, which had a high suicide rate, implemented means reduction by banning hazardous pesticides, and they were able to reduce their suicide rate by 50% over a 10-year period. Very simple to implement. There are many, I would say, advocates on suicide prevention who are advocating this with the government. If the agriculture department could take this into cognizance and look at pesticide banning to reduce suicides. We know that 25% of suicides in 2021 were due to poison. Again, we don't have the breakup available about what percentage within this is pesticide, but assuming there is certain percentage that can be worked upon. The other thing that we had recommended was direct transfers. That is something that Indonesia had implemented. Again, if you look at the NCRB data, 25% of people who died by suicide were daily wage earners. There was an additional 8% of people who were unemployed, which means that 1/3 of the population may have been people who had a weak financial position. A scheme like direct transfer, which identifies which are the groups that experience this at a very high level and can provide this kind of program delivery, could lead to a reduction in suicide. There's another project called Project Trevor, which is a helpline, which is US based. We're trying to find a similar helpline in LMICs. Unfortunately, we couldn't find. But what Project Trevor does is that it works with the LGBTQI community, and the helpline is specifically for that community. And of course, it has a very strong referral systems attached to the helpline. As I was saying before, we know that suicide among young women is a big issue in India. That's a marginalized group. So is there a need to have a dedicated helpline to work with young women? Will it give more results than a general helpline, where probably the counselor on the other side needs to have a lot more experience on multiple facets and issues, whereas a helpline that works dedicatedly on a particular issue may have deeper knowledge and better referral systems. So that's again a third kind of intervention that we think that can work in India. And I think the fourth example we gave is something which is implemented in India. Arjun had started off by saying education is a big stress among students, common exams, and we are seeing even now the NEET and increased death due to suicide, pre-results and even post-results. There's a research that was done by Dr. Lakshmi in Tamil Nadu that said that introduction and promotion of supplementary exams for the 10th and 12th boards can reduce death among student community. Again, that's 8% of the community that got impacted in 2021. So I think there is enough data that is available to us. There are enough practices that have made sense in other similar low-cost settings, which actually are sitting within multiple departments. So it's not that the health department has to take all of them. Issue on education on supplementary exams can be taken by the education department. A helpline for women can be taken by the WCD. So there are multiple departments that can choose to adopt a single program that is easy to implement, has enough research outside of India to say that it should be utilized, and work immediately on drafting a policy and implementing it.
Right, that's really helpful, Preeti. And I think one of the insights that emerges from some of the interventions that you've shared is that, of course, there is no one size fits all when it comes to suicide prevention. And we have to think of a multiplicity of strategies which address a wide range of populations, which address a range of factors, risk factors, which contribute to suicide. So thank you for that. I think that, that's a rich sort of exposition of what some of these diverse strategies could look like. And I'm sure there are many more out there, and which hopefully researchers in India and even policymakers will draw upon to sort of adapt and implement in India's context. We've got about 10 minutes left, and there are lots of questions coming in, but I have to come to you, Arjun, right now, and sort of hopefully end this discussion, with you. Your own journey and recovery from depression has been nothing but inspiring. You have now sort of you're also playing a very proactive role in doing advocacy on social media. You've started a new initiative, as we described in your introduction. You've also written a book, and looking forward to seeing whether you come up with another book in the future. But just wondering if you can talk a little bit about your own journey of recovery. What are some of the sources of support that you relied upon? And also, importantly, there might be people today who are listening in on this discussion who might be struggling with their own difficult feelings. Can you share any message for those who might be listening in? And also, more importantly, what can we as citizens, policymakers, civil society do to support those who might be struggling with thoughts of ending their life? Over to you, Arjun.
Right, so there's a lot to unpack there. So I'll just start with my recovery journey. And so I was 17 at the time. I was preparing for my admission in MBBS program in Rohtak, and suddenly, all of a sudden, I found myself just surrounded with completely negative thoughts. And I think it was within 2 months that I went from being such a high achiever who had just gotten an amazing result in the AIPMT exam to just being someone who was very severely depressed, actively suicidal, and indulging in self-harm very regularly. As with most things, we've talked a lot about stigma. I think the worst form of stigma I struggled with was self-stigma, because I was not willing to admit that I had a problem or that what I was going through was some form of a illness. And it was my parents actually who were the most important support mechanism throughout that, because they were the ones who took me to a psychiatrist first. They took me to a psychologist. They took me to Bangalore to get treated in NIMHANS, and they were willing to stay with me there, just leaving their whole lives behind and their whole work behind, just to stay with me there, just to make sure that I was safe. And I think it took a lot of suicide attempts to realize that of the many competencies that I have, dying is not one of them. So I eventually moved on from that idea. And I remember it was after my third attempt that I made a public appeal on my social media page that I just need some help. I cannot do this alone, and uh, I don't think I can make it. And thankfully, the response from the community was immensely positive. My teachers, my school juniors, my seniors, everyone got in touch with me, and they tried to um, encourage me to take some help. They encouraged me to, they made me believe that what I had was solvable, that it could be cured, or it could be something that is not permanent in my life. So I think that's what brought me on this road. I think the public support, the support of my family, and that's something that I'm really thankful for. I don't really like giving messages to people who might be in a similar space because, again, as you said, no one size fits all. And I think I might end up giving some advice which I found unhelpful myself at the time, and I found very irritating. So I'll stay off on the advice bit. And when we talk about citizens, policymakers, and advocacy groups, there's a lot of different things that people can do. Citizens, they can do what the citizens of my city did, just be there to support me. And instead of, saying that I have some dark energy ka prakop on me, or that I'm being influenced by some evil spirits, just try to support me through that, through scientific means. And maybe some training in how to identify suicidal symptoms or symptoms of psychological distress would help people. Policymakers, I think, as this whole discussion has been so centered around intersectionality, I think the more diverse approaches that we have, the more diverse inputs that we take as policymakers, as advocacy groups, the more holistic we will be in our approach. And as the last end of the conversation was, we need better data, we need better research to understand, the phenomenology or the experience of people who are going through this. So there's a lot to be done, of course, but I think this is a pretty good place to start. We all start with a conversation, and yeah, that's pretty much it from my end.
Thanks for that, Arjun. Appreciate your point of view, and thank you for sharing your journey with us. We're sort of towards the end of today's discussion. We're at 2:56 p.m. Sorry, we are at 8:56 p.m. Unfortunately, we will not be able to address all the questions. I know there's been a lot of engagement that has come in through the audience, and really thank you for engaging with the discussion. We'll try and sort of find a way to sort of respond to these questions if possible after the discussion. But given the fact that we have about 3 minutes left, I think I will have to wrap up this discussion. I don't have much to say apart from the fact that this has been an extremely insightful, thought-provoking, and educative discussion for me, at the very least. I'd just like to end with a simple message that suicides are preventable, and that there are evidence-based interventions out there which have proven to have sort of prevented suicides. And these are interventions which touch upon a range of factors which affect people. And these are factors, like I mentioned previously, which are social, economic, cultural in nature. A national suicide prevention strategy is, of course, a reflection of a government's commitment to preventing suicides, and we hope that this discussion will build the momentum, will start many more discussions and conversations, and hopefully initiatives, and of course engagement with policymakers, so that we can come up with a suicide prevention strategy for our country at the earliest. So on that note, I'd like to thank all the panelists for engaging and sharing their thoughts and insights. It's been extremely wonderful to have heard and been in conversation with you. So thank you for that opportunity. I would now like to hand over to Dr. Soumitra Patare, Director of the Center for Mental Health Law and Policy, Indian Law Society, to deliver a note of thanks. So over to you, Samudra.
Thanks, Arjun. I'm not going to keep you any longer from your dinner. I'm sure this is late for all of you, so I will wrap this up quickly. I just want to start off, first of all, by thanking all of the participants who logged in to listen to this. I mean, it's always a great thing to see that there were so many people who do have an interest in suicide prevention. I want to thank my team for all of the work that they put in to do this. And I'm not going to name everyone individually because there are many more people than the ones you see here online who actually have worked behind the scenes to get this program in shape. I also wanted to thank our interpreters for a wonderful job done, as Joe said in the chat, very graceful and very well done. So thank you so much to the interpreters. And finally, and not last but not the least, to thank our panelists, Urvashi, Preeti, and Arjun, for being here and sharing your insights on this issue. I'm just going to wrap up by taking 30 seconds to say what I learned out of this. I think, one of the things that I realized from what Urvashi was saying, which is completely true, is that while we need to think national, we need to act local. So the action has to be at the state level, while the national policy might actually do something which is which is kind of lays out a roadmap. The action has to be at the local level. I thought Preeti made a very important point about the whole idea around marginalization and the need to include people into the conversations, and the need to kind of think about a lot of interventions and implementation and research that is possible in our country and has been done in other places. So that's a very useful thing for all of us to remember. And I think Arjun did touch upon this particular point, and I wish we had more time to talk more about this, which is to do with the role of media, not just social media, but even broader media. And maybe we should have a different discussion on the role of media as well as social media in suicide prevention. I want you to go back thinking of one thing, that actually there is a lot of low-hanging fruit which does not require resources, a lot of resources, and in some cases no resources for us to do in terms of suicide prevention. And you'll say, like, give me an example. Well, one example is addressing this whole issue around decriminalization of suicide that has happened. Getting our police forces to actually kind of work in tandem with what the law is now trying to say. And that's not going to cost anything. It's just going to require a certain amount of doing things differently. Another low-hanging fruit is media. I mean, getting our media to report suicides better, getting social media to do things better doesn't cost a lot. It's not going to mean a lot of money. And then there are some things which will cost a little bit of money, but could actually be great things. Like, for example, if we started a national fund to fund all suicide prevention helplines. Now, government has tried to do it with Kiran by putting up a national helpline, and we know that it hasn't been a roaring success. But it would also be a great thing for government to put up a national fund and fund NGOs to do these suicide prevention helplines, talking about what Urvashi said about intersectoral collaboration. It would be a good example of government actually bringing civil society in to kind of share the burden with them. I'm going to stop here and not go on any longer. Thank you all for being here. Thank you, everyone. And I'm going to hand it back to Tanya to close this session.
Tanya, you're on mute.
Thanks, Arjun. Thank you, everybody, for being here. Thanks once again to our panelists and all our attendees. I hope you have a good night, and we will be in touch with all resources and updates from the center. Have a good night.
Thank you.
Thank you, everyone.